As Savannah said, my name is Dr. Vincent Buddle. I'm one of the orthopedic spine surgeons here at Seaview Orthopaedics. And today we're going to be talking about back versus leg pain and why the difference is so important. I'd just like to first take a second just to say thank you to Savannah and the marketing team for helping me put this together. And thank you to all of you guys in the audience for taking time out of your evening to listen to me speak today, especially with the weather being so nice out. All right, and then as Savannah said, I'm happy to answer any questions or concerns at the end of the presentation, so there'll be plenty of time for that as well. So Savannah mentioned this a little bit, but just a bit of a quick introduction. I am a local guy. I grew up right here in New Jersey, specifically Wall Township, New Jersey. I attended the Academy of Allied Health and Science for high school. I then went on to Monmouth University, where I majored in chemistry with a concentration in biochemistry. At Monmouth, I was accepted into the Monmouth-Rowan 4-4 program for medical school, and subsequently went to Rowan University's School of Osteopathic Medicine for my medical training, and then stayed in the South Jersey, Philadelphia area for residency at the Jefferson Health System of New Jersey, where I completed my 5-year orthopedic surgery residency. And my formal training ended in Michigan at nationally ranked hospital, Beaumont Hospital in Royal Oak, Michigan. Beaumont Royal Oak is a major level 1 trauma center for adults. It's a level 2 pediatric trauma center or a level 2 pediatric trauma center, in addition to being a spinal referral center, mainly for Southeast Michigan, but really all of Michigan at this point. My fellowship year was an extremely busy academic year. I completed over 550 cases and really had the distinct honor to learn and perform surgery with not only nationally, but some world-renowned surgeons. So just a quick sort of summary of what we're going to be going over. Anybody who's heard my talks before has heard me talk about anatomy and how I really stress the importance of understanding anatomy being the key to both understanding non-surgical and surgical options for the treatment of really any spinal pathology or really anything in orthopedics. So we'll go over some normal spine anatomy first. We'll then talk about some of the main causes of back pain. We'll then talk about what causes leg pain, numbness, or weakness. We'll then go into why it's so important to distinguish between the two. And then we'll talk about how you treat back pain, how you treat leg pain, numbness, or weakness. And then again, as I mentioned, I'm happy to answer any questions at the end of the presentation. So we'll begin again by talking about the normal anatomy of the human spine. So my mentors from medical school, residency, and fellowship really emphasize the significance of understanding human anatomy, both in surgical procedures, but also in the patient-doctor discussions. And so the anatomy really provides a comprehensive understanding of the surgeon's actions during an operation, and I think it really helps understand the rationale behind doing certain things, and thereby it reduces a lot of confusion for the patient and subsequently a lot of anxiety that might surround the treatment of spinal pathologies. When you look at the human spine, it's typically made up of 7 cervical, 12 thoracic, and 5 lumbar vertebrae in conjunction with the sacrum and the coccyx. The accompanying images, if you see here, when you look at the spine from the front, it's normally straight up and down. And when you look at the spine from the side, it has what we call normal cervical lordosis, thoracic kyphosis, and then lumbar lordosis. And these anatomical features are essential for the spine's function in collaboration with the pelvis and the hips, which enables us to have this upright posture without significantly bending at the knees or looking up at the sky or looking down at our shoes when we walk. The images over here on the right show the individual vertebrae or the individual pieces of the spine, which fit together almost like a complex puzzle piece or a complex puzzle. And so the human body's design is really incredible. And so it provides us with all these moving parts which allow us to bend, rotate, but it also provides stability and protection to the very delicate spinal cord and nerves that live within them. And when you look at this image on the top here, this big hole is where the spinal cord resides. And if you look at the spinal column closely, these smaller holes on the side, which are called foramen, are where the nerves exit to go out and innervate various parts of the body. With an understanding of more of the bony anatomy, we can kind of go on to the main causes of back pain. And so before we specifically talk about causes, back pain as a whole is a really big societal issue. And it's going to significantly affect around 50 to 80% of the population at some point during their lives. So you're talking about a large number of people who are going to suffer from back pain. There are several risk factors, such as smoking, obesity, lifting heavy objects, prolonged sitting, and all of these things can increase the likelihood of a patient having back pain. I'm going to address this a little bit later in the presentation, but smoking is an enormous risk factor when you're talking about really any treatment for spinal pathology, but specifically surgical treatments. Smoking in some instances can be considered a strict contraindication to surgery, specifically because it increases the risks of having things like the bones not fusing together, which can lead to a non-union, or wound healing issues, which can lead to an infection. And an infection in your spine can really be a devastating and potentially deadly complication. But what's the main cause of back pain? Well, the most common cause of back pain in really any age is going to be a muscle strain. And so the bones of the spine are encircled by a large number of muscles. And what I did here was I highlighted some of the more common muscles that get strained and can lead to back pain, all the way from your cervical spine down to your lumbar spine. So you have here your posterior cervical musculature, you have your trapezius muscle, your latissimus dorsi, your rhomboids, and then you have your erector spinae muscles, which run in parallel to the spinal axis. Any one of these muscles can cause a strain, and any one of these can cause a significant amount of back pain. In addition to muscle strains, there are several other causes of back pain, and these can include things like degenerative disc disease. So the image here on the left and the image here on the right are an X-ray and an MRI, respectively, of a patient who has degenerative disc disease. And you guys can see my cursor, correct?
I don't think so.
No? Okay, so
Oh, wait, no, we can.
okay, so over here, the red box on the image on the left, you can see this patient at L5 and their first sacral level has significant degenerative disc disease. If you look up here at their higher lumbar vertebrae, this is what a disc should more normally look like. There's a wide space and it's not collapsed. Similarly, when you look here on the MRI, this disc is black and worn out, and the disc height has collapsed, as opposed to the disc up here, which is wider and has more white and more fluid in it. This degenerative disc disease can lead to a specific type of back pain. It's called discogenic back pain. And patients will classically come in with pain across their back, and it really is usually not accompanied by any sort of leg pain. In addition to degenerative disc disease, the image here on the right shows some arthritis in the facet joints. Facet joints are small synovial joints in the back of the spine. And I stress that they're synovial joints just like your hip or your knee. And so therefore they're prone to things like osteoarthritis and causing pain, just as a person can develop pain in their hip or their knee if they develop arthritis. And so muscle strains, degenerative disc disease, facet arthritis, it's definitely not an all-encompassing list, but these are, again, the more common causes of back pain. And so individual x-rays or individual advanced imaging, such as CAT scans or MRIs, can help me figure out if there's other etiologies to causing a patient's back pain. And so with that sort of general understanding of back pain, well, what causes leg pain, numbness, and weakness? And so again, just as I started with the lecture, anatomy really is the key to understanding. And so I apologize, this is a bit of a busy slide, but what it demonstrates is the Asia dermatome map and the specific muscles innervated by each nerve. And so this is a standardized image that physicians use to accurately and consistently examine patients' motor strength, sensation, and other neurologic functions. And so humans, for the most part, are wired the same way. Specific nerves innervate specific areas on your body and specific muscles. So if you have compression of your L5 nerve root, you'll predictably come in with pain to the top of your foot and difficulty bringing up your big toe. And so this anatomic mapping is really key to understanding because this is what makes for effective spine surgery. And I'll discuss this a little bit further in the treatment section. But the question then becomes, well, what's actually causing the nerve pain? And typically it's compression. Again, there's several causes of compression of the nerves. And just like the low back pain, this is definitely not an all-encompassing list, but again, demonstrates the more common causes. And so a common cause can be stenosis in the spine. If you develop arthritic changes in your spine, the soft tissue structures that help support the spine can swell. This can lead to compression of the nerves. So if you look here on the left-hand side of this image, these nerves are open, they're not being compressed. If you develop arthritic changes in the joint, your soft tissue will swell and it will subsequently cause compression of the nerves. This center image is an image that we saw on a previous slide, but now we're focusing on the disc herniation. And so if a disc herniates backwards into the spinal cord or into a nerve, it can cause pain to radiate down the leg, and it can be associated with numbness and weakness. Again, similarly, I pointed out the foramen on the first slide of the bony anatomy of the spine, and you can develop arthritic changes within the foramen. So if that hole where the nerve goes out to innervate various parts of the leg becomes compressed, it can lead to pain, numbness, and weakness going down to the leg. And so why is this important? Well, this really takes us to like the subtopic, if you will, of the presentation. And so the main reason is that pain, numbness, and weakness can be treated surgically, while primary back pain is typically not treated with surgery. And again, if you go back to the anatomy, leg pain, numbness, and weakness is the result of compression of the nerves in your back, which essentially tricks your brain into thinking that the problem is in your leg when it's really in your back. If you look at spine surgery really at its simplest form, it comes down to if you take the pressure off of the nerves, there's a good chance that your pain will go away or at the very least be significantly reduced. And it gives us the best chance for you to have motor and sensory function return. Now, this isn't to say that there aren't treatment options for back pain, right? So what are those treatment options? Well, they're typically your non-surgical treatment options. And these things include physical therapy, non-steroidal anti-inflammatories, Medrol dose packs, acupuncture, chiropractic care, heat and cold therapy. And so the difficult thing with these non-surgical options is that they're not a quick fix, right? They're labor and they're time intensive. Depending on a patient's insurance, they can be expensive. And sometimes with physical therapy, you can get slightly worse before you get slightly better. But these recommendations for how you treat back pain are not just my recommendations, right? These are backed by several publications and years of research and the support of both national and international societies that really guide orthopedic treatment, including the American Academy of Orthopaedic Surgeons and the North American Spine Society. And so I wanted to include this article in this presentation. And so this is just one example that supports non-surgical treatment or non-surgical management in the treatment of back pain. And so this article is from the Journal of the American Academy of Orthopaedic Surgeons, and I highlighted a couple segments of the article. And so you can see here, it says, in most patients with low back pain, symptoms resolve without surgical intervention. Physical therapy and non-steroidal anti-inflammatory drugs are the cornerstones of non-surgical treatment. Physical therapy with strengthening of core muscle groups, both abdominal wall and lumbar musculature, has demonstrated positive effects in patients with just discogenic pain. So wearing out of the disc, if you strengthen the muscles that surround the low back, both in your abdomen and in the low back, you'll see positive effects. This one, the authors reviewed 51 trials and over 6,000 patients and found that NSAIDs are effective for short-term symptomatic relief in patients with acute back pain. No specific NSAID was found to be more efficacious than any others. Basically, what that's saying is whether it's Advil, Aleve, Motrin, generic NSAID from CVS, Walgreens, whatever it might be, they all have the same effect. And then these are probably two of the most important highlighted segments. So if you look at arthrodesis of painful lumbar motion segments remains controversial form of treatment, and fusions have been criticized for providing inconsistent results. And so this is a conversation that I have with patients a lot of times, right? And these are the studies that show us that fusing for primarily back pain is not necessarily the right answer. And it's definitely a controversial topic. And so that's why we push for conservative or non-surgical treatment options for back pain. Well, what about leg pain, numbness, or weakness, right? Well, there definitely are surgical options for leg pain, numbness, and weakness. And again, I included a list of a few of the spine procedures that we can do. Again, simplest form of spine surgery, where the main goal is to decompress the nerves. And so, depending on a specific patient's pathology, where the nerve is being decompressed, how much bone I have to take away, really dictates what procedure is done. So it can be anything from a minimally invasive discectomy to what this patient had here on the right side, which was an open, lumbar fusion. My main goal is always decompress the nerves, and if I have to stabilize your spine because I took away a lot of the bone, that's sort of a secondary procedure in my mind. And how do you get to those surgical options, right? Well, pain, numbness, or weakness in your legs. You then have to have failed 6 weeks of conservative management. Conservative management is physical therapy, non-steroidal anti-inflammatories, and occasionally injections can be sort of the middle road option. You then have to have corresponding imaging, right? So 100% of the patients that I take to the operating room have x-rays. 100% of the patients that I take to the operating room have an MRI. The CAT scan is a little bit of a tweener, if you will. I really only get CAT scans on patients that I need to evaluate their bony anatomy a little bit more in depth. And then the last sort of piece of the puzzle is you need medical clearance for the operating room. If you have any sort of cardiac issues, you need to have cardiac clearance. And then you really need to understand the risks of surgery, right? And if you understand the risks of surgery and you're willing to take those risks for the potential benefit, and all of these other things line up, these are the people that have the best chance of having a good outcome with spine surgery. And with that, as Savannah said, I do see patients in all of our offices. I'm happy to see anybody at any location, and I'm happy to answer any questions or concerns that the audience might have at this time. And I'll pull up the chat as well.
So like I said earlier, if anybody feels comfortable, you can go ahead and unmute to ask your question. Again, just please try to keep them generic. We don't want too much personal medical information going out there. So unmute or type in the chat.
I have a question. So if you have pain in your lower back and also in your lower leg without numbness or weakness, is that a back issue or a leg issue?
Yeah, so that's a good question. It could be both, right? So I do see a fair number of people who have both back and leg pain, right? And so if you have, for an example, say you have a herniated disc that's causing a compression of a nerve, right? That can cause a degree of back pain because your body is having an inflammatory response due to the herniated disc. The important distinction and the question I ask people is what's worse? And so for me to start talking about surgery, the answer either needs to be my leg pain is worse than my back pain, or they're equal. And so if a patient tells me that their back pain is their primary problem and their leg pain is secondary, I tend to steer them away from surgical intervention because I can't guarantee that you're going to have a good outcome. I think a more realistic expectation is that if you have a component of back pain and you have a component of leg pain, if I successfully take the pressure off of your nerve, good chance that your leg pain gets better. The possibility of your back pain getting better is about 50%. So 50% of people will see some improvements in their back pain, and 50% of people will have the same level of back pain, and we treat them, again, conservatively, physical therapy, long-term medication, injections.
Okay, so follow up. So when you have back fusion, can that cause you to have problems down the line with another section of your spine?
Yes, so it can. The biggest concern with a fusion is something called adjacent segment disease. So what adjacent segment disease is, and I'll actually back up to, so if you look at this patient right here, so she has a 3-level fusion, adjacent segment disease is worrying about this level above or below a fusion. And if you fuse 2 motion segments together or 3 motion segments together, the levels above and below are now going to absorb more motion and they can degenerate faster. The rate of adjacent segment disease is about 20 to 27% at 10 years. So I really tell people, like, yes, it's a concern. It's a risk that I talk about before surgery. But if you're having severe leg pain and I need to fuse you because I need to take down a significant portion of your spine to decompress the nerves, don't let a 25% chance, if you will, at 10 years sort of steer you away from it. There are certain things that we do in the operating room to try and um, minimize the risk of adjacent segment disease. So when I fuse the spine, so at this level, this was the what we call the 2-3 facet joint. You don't disrupt the joint capsule, and you leave it like very carefully intact, and that helps reduce the rate of adjacent segment disease. There's also some evidence that if you use robotics and have like robotic navigation, it can help you more accurately place the screws and avoid adjacent segment disease, or at least decrease the rate of it.
Thank you.
Of course. Looks like Michael asked the question, if you're having severe pain on the side of your buttocks and your heel, do I need therapy or to see a spine surgeon? I would say that if you haven't done any, well, either way, I'm happy to see you. But if you haven't done any conservative management, the first step is to try physical therapy, at least for 6 weeks. And then if your pain is still persistent at that time, then that's when we start getting advanced imaging like MRIs, and then the potential role of spine surgery comes in. Looks like Walter Wentz said, sciatic issues and pain radiating down your leg. Is it your back or leg issues and physical therapy, or can you do therapy at home? So it's a good question. So again,
I want to ask him about acupuncture.
So sciatic pain is more like a generic term, right? The technical medical diagnosis is something called lumbar radiculopathy. It means compression of the nerves in your lumbar spine that causes pain radiating down your legs. The term sciatica came from the actual nerve itself. The sciatic nerve is what runs in your sort of like buttocks region. And your sciatic nerve can be compressed in other areas, not just in your spine, but certain muscles can compress it as well. Things like piriformis syndrome. And so if you're asking whether it's a back or a leg issue, so the root cause of it is in your back. The nerves are being compressed in your back, but you're going to feel pain in your leg. Now, similar to the first question we had, you may experience some back pain, but it's a problem in your back that's causing leg pain. Oh, and then the second part of your question, physical therapy or can you do therapy at home? So yeah, I mean, you can do therapy at home. There is a very good website that I can write in the chat. It's called OrthoInfo, and it's put out by the American Academy of Orthopedic Surgeons. If you Google that, you type in low back exercises, AAOS, there's a home physical therapy program. The only problem with doing therapy at home, and you can thank the insurance companies, is that if you come and see me and you say, hey, I did 6 weeks of therapy on my own, that's great, but the insurance company is going to deny your MRI because they want you to do formal physical therapy, formal conservative treatment, and not get better after that, and then they'll approve your MRI.
I will throw out that we offer physical therapy at all 6 of our offices.
Is injections safe to take? So yeah, so injections are safe to take. Injections are sort of like a nice middle ground for the treatment of spine pathology, right? Sometimes people come in and they're not, they have leg pain from a herniated disc, but they're not necessarily willing to undergo surgery, and they don't have any like numbness or accompanying numbness or weakness. So an injection can be helpful. And I tell patients that injections can be therapeutic or diagnostic. Therapeutic in the sense that you get the injection and your pain goes away and you get some nice long-term relief from it. And I sort of joke with people, I say, you get the injection, you get long-term relief, you come back into the office, we high-five each other, and you're good. You just live your life and you have you're pain-free. Or it's diagnostic in the sense that you get the injection and the pain goes away for like 2 days. And that's disappointing, but it at least gives us further confirmation that that is the problem, and that if I take the pressure off of the nerve, that you'll probably have a good outcome after surgery. Next question is, please explain nerve ablation. Yeah, so nerve ablation is more of like a pain management procedure. It can be dependent upon which nerve you're specifically talking about. There's a lot of the pain management doctors will do what's called a medial nerve branch block. And so what they're doing is they're targeting the nerves that innervate the actual structures around the spine, not necessarily the nerves that innervate your leg. And so the medial nerve branch block sort of gives you an idea, if you ablate the nerves, whether or not you'll have a good outcome. And so ablating the nerves that innervate around the spine can be a good treatment for axial back pain. There is also some evidence about a procedure called the intercept procedure. I did do it in fellowship. I learned how to do it. I have not done it as an attending, but it's essentially burning the basivertebral nerve, which is the nerve within the vertebral body itself. There's some pretty good evidence from like a long-term standpoint that that is a good solution for axial back pain. Do you feel that acupuncture helps with back pain? I do. I kind of walk a fine line with acupuncture. I do think it helps. I think it's potentially it's a low risk, potential high reward. It can help alleviate muscle tension. I will say that like the formal stance of the AAOS with acupuncture is that it technically falls into the non-conventional modalities, but I don't have an issue with patients doing it. I think that if you can alleviate muscle tension with acupuncture, it's great. And I think, do all of our physical therapy places offer acupuncture, or is it just Homedale and Ocean?
All of our offices have it.
Yeah. So it's a good option for patients. Which kind of brings me to that next question: can chiropractic care be the first option, or is it not really effective? So, I mean, I don't have a problem with patients seeing chiropractors. But again, similar to acupuncture, from like a true orthopedic standpoint, it technically falls into the non-conventional modalities. The other problem with chiropractic care, and it's understandably frustrating for patients, is that you can be treated by a chiropractor, kind of be getting better, and then come and see me and ask for an MRI. Insurance companies are going to want formal physical therapy for the MRI to be approved. So, chiropractic care is fine, but you may not get an MRI if you just have chiropractic care.
Anybody else? Feel free to unmute or type in the chat. We'll wait a minute just in case anybody's typing before we finish for the night. There we go.
Okay, so do you use robotics for spinal stenosis? So yeah, I am trained on the robotic spine surgery. Specifically, it's called the Medtronic Mazer robot. There are a bunch of different ways to utilize the robot, and it's definitely been a debate among spine surgeons whether the robot is, sort of worth the time and the money. I will say there's definitely a role for robotics, right? But again, it always comes down to truly understanding the anatomy. And so the robotics can help surgeons place screws. But ultimately, if the robot kind of fails, the surgeon has to be able to put screws in by themselves or put in spinal hardware by themselves. And so the robot is also going off of the guidance of imaging. And so if the imaging is off, it can lead to devastating consequences. Now, that doesn't happen, or rarely happens, I should say. The robot technology is significantly advancing, particularly like as AI starts to creep into the medical field. Um, uh, but yeah, there's certain patients that I use the robot for, revision surgery if I can't really see the normal anatomical landmarks. I don't use it for all my cases, but if someone specifically asked for it, I would be happy to use it. Um, why would an epidural injection not work if the fluoro showed the nerve? So an epidural might not work. I guess it kind of depends on what you're getting the epidural for, or what your treatments are, right? Sometimes there's just too much compression of the nerve, and even a local injection and a local anti-inflammatory may not provide relief. And so if a patient doesn't, has an MRI that shows that they have significant stenosis or significant compression of the nerve, and they get an epidural and it doesn't work, then that's when a potential surgical, conversation is going to be had. Because at that point, myself and the patient can look at each other and say, listen, we've tried everything, right? We've tried physical therapy, we tried medications, we tried an injection. Nothing's getting me to the point of where I want to be. And if your MRI matches with the symptoms that you're feeling, then that's a potential good candidate for surgical intervention. So Carol said stenosis, 85 years old. Is this too old for this kind of surgery? Short answer is no, right? Age to me is just a number. It's more important about your overall medical status, right? It's unfortunate to say, but I have, see 40-year-olds that have a laundry list of medical complications that would not be surgical candidates. And then I see 80, 85-year-olds who are very healthy, have minimal medical problems, and they're people that do well with surgery, right? I mean, it's a bit of a consideration, but if you're otherwise healthy, then no, 85 years old would not be a contraindication to having surgery. Is it likely that headaches can be the result of back pain? Yeah, so headaches can be caused by muscle strains, particularly not necessarily if you're talking about the low back, but if you're talking about your cervical spine, the muscles that hold up your head insert on the back of your skull. And if you strain them, it can be very painful. It can last an extremely long time. I see it send people to the hospital if the pain gets really bad. And so, yes, neck pain and muscle strains can absolutely cause headaches. More classically, people will say, I have pain kind of like wrapping around my head, or I feel pain in the back. There's other causes for headaches. A lot of times I'll have them start PT in their neck. Then I'll ask patients to see their primary care doctor or a neurologist to make sure that there's not some other root cause of causing the headache. How long does it take for a nerve to heal? So that's a loaded question. The short answer is, you take the pressure off the nerve. Some people see, immediate relief. They wake up and they're like, hey, my leg pain is gone. Other people, if the nerve has been compressed for a long time, it can take a significant time period for it to recover, and sometimes it doesn't. And when I say a significant period of time, I usually tell people you can continue to see improvements for up to a year. That kind of brings me to something I wanted to mention. So if you have numbness or you have weakness, that typically indicates to me that the nerve is being a little bit more compressed than it likes. Pain is one thing. You take the pressure off the nerve, like I said, good chance that your pain will go away. But I never guarantee people that numbness or weakness will return. It gives you the best shot of having your your sensation and your motor function return. But if you start noticing weakness in your foot, or your foot is like completely numb, the nerve has been damaged. And so it may take a while, or it might not come back at all. And again, the best chance is a successful decompression. And then, in the post-operative period, providing yourself with, the best nutrition, high protein, to sort of help facilitate the nerve healing. Should you exercise with back pain? So again, the question, it's kind of like a yes and no answer, right? If you have new onset back pain and you're a very active individual, I tell people to dial back their gym activity for 2 to 3 weeks. Go to formal physical therapy. The physical therapists typically start you out slow with stretching exercises, deep tissue massages, low weighted exercises, and then have a conversation with the therapist about what you like to do in the gym or the activities that you like to do or how you like to exercise. And the therapist will get you to that goal. They'll start teaching you how to warm up for those exercises so that you're not going from cold to hot. So, yes, you can exercise with back pain, but if it's hurting you, then you need to stop and we need to reduce your activity and do the proper physical therapy. It kind of sounds silly, but there is a treatment component to back pain that is activity modification. And simply put, it's kind of the old saying: if it hurts you, if it hurts you while you do it or after, stop doing it, at least temporarily.
All right, I think that is it for tonight. So I just want to say thank you again for everybody who jumped in tonight. I know it's a beautiful night out, so I appreciate you all being here on your computers with us. So if you do have any unanswered questions or any other concerns, maybe some more specific things, Dr. Buddle is accepting new patients. Again, all 6 of our offices. So you can book with him online at www.seaviewortho.com, or you can call us at 732-660-6200. So if you jumped in late and you missed my little intro, we do these virtual education seminars every other month. So if you want more information about that, you can go to our website under upcoming events. And another way to stay up to date on everything we do is to follow us on socials. We are at Seaview Ortho on Facebook, Instagram, TikTok, LinkedIn, and Pinterest. And we have a podcast called the Seaview Ortho Podcast that you can listen to on any podcast streaming platform. So if you want more of Dr. Buddle, he was our most recent podcast guest and provided some great education on spinal fusions. And of course, you can sign up for our newsletter at seaviewortho.com, and all of these wonderful things will get sent straight to your email. So again, the presentation is recorded, so it will be sent to your emails. Just give it like 24 hours and I'll get that over to you in case you wanted to rewatch. And thank you, Dr. Buddle, for taking your Tuesday, Wednesday, what day is it? Your Tuesday afternoon and spending it with us.
Yeah, thank you. I appreciate everyone's time. And I think the most amazing part is that my daughters were not screaming at any point during this presentation. So,
Amazing.
all right. Thanks, everyone. Have a good night.
Good night, everyone.
Bye.